My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Center in Boston, Massachusetts. The routine use of sentinel lymph node biopsy in women over the age of 70 with clinical T1N0 hormone receptor positive breast cancer has been called out by the Society of Surgical Oncology as one of their top measures for the Choosing Wisely campaign. The Choosing Wisely campaign is meant to inform both providers and patients of procedures which may not be medically necessary in all cases and may lead to overtreatment or increased cost of care in certain populations. The focus on the routine use of sentinel lymph node biopsy in this older population with early stage hormone receptor positive breast cancer is important because there's actually data from prospective randomized clinical trial run by the CALGB demonstrating the safety of omitting the sentinel lymph node biopsy procedure, or in fact, the safety of omitting any axillary lymph node evaluation in this older population of patients with early stage hormone receptor positive breast cancer. So in fact, the CALGB trial enrolled women over the age of 70 with, again, early stage hormone receptor positive breast cancer. All patients underwent lumpectomy, and the randomization of this trial was actually to whole breast radiotherapy or observation only. The study's primary endpoint was actually to look at local failure in the breast with de-escalation of treatment in this older population. The interesting thing about the study, though, which was again borne out in the long-term results, was that in fact 60% of the women enrolled in the CALGB study had no axillary staging evaluation whatsoever. Again, this was not a primary endpoint of the study, but axillary staging was not mandated. So 60% of women had no axillary staging procedures, and the rate of local regional recurrence or axillary failure in that trial at 12 years in the patients that had nothing done to their axilla was about 3% compared to 1% in the group that did have an axillary staging procedure. So this actually was the first evidence, again, although the study was not directly designed to ask this question, this was the first time that people really started questioning, well, do we need to evaluate the lymph nodes in all of our older patients with early stage hormone receptor positive breast cancer? If it doesn't have an impact on local regional recurrence and it doesn't have a significant impact on disease-free or overall survival, then can we avoid the morbidity of the procedure in this group of patients? There, of course, have been several other randomized trials looking at axillary node dissection versus no axillary treatment in older women with early stage disease, primarily hormone receptor positive disease. Many of these trials were run in Europe through the 80s and early 90s, and these studies also demonstrate no significant difference in local regional recurrence, disease-free survival, or overall survival in this group of women. So in the last decade or so, again, with the advent of the Choosing Wisely campaign, many providers and groups have asked, do we need to perform routine sentinel lymph node biopsy in these patients? Our stance is that if the decision for systemic therapy has already been made, and largely in women over the age of 70 with hormone receptor positive disease, the decision for systemic therapy is really centers around the use of hormonal therapy or endocrine therapy, whichever term you like to use. There generally is not a question about, are we going to give this patient chemotherapy? So if my medical oncology colleagues have already made their decision that they know their systemic therapy for this patient is simply going to be endocrine therapy, then the information gleaned from the sentinel node procedure in that setting is not going to change their practice. And again, with this information, combined with what we learned from ACOSOG Z11, where we know that even women with 1 or 2 positive sentinel lymph nodes did not experience any benefit in local regional control with axillary node dissection compared to those where axillary node dissection was omitted. These data also indirectly support the fact that even though some of these women may have disease in their axilla, it is likely not going to become clinically apparent or going to impact their clinical outcomes. So at our institution, we do not routinely perform sentinel node in women over the age of 70 with T1N0 hormone receptor positive breast cancer. There may be an exceptional or an outlier case where the individual herself is particularly motivated to have a sentinel lymph node biopsy procedure, and certainly we don't want to deny women the reassurance that their nodes are negative if this is important to them in their treatment planning. But most women are very comfortable once we explain the data to them, once we explain that the findings of the sentinel lymph node won't change their treatment. They are very happy to avoid the potential morbidity of the sentinel node procedure. Now, again, it's important to remember this is only in the hormone receptor positive subgroup. Certainly in women, in older women with higher risk disease, such as triple negative disease or HER2 positive disease, our medical oncology colleagues are often really looking to the information from the sentinel lymph node procedure to make those systemic therapy recommendations. And in those cases, we certainly do still routinely perform the procedure, again, weighing the patient's comorbidities is certainly always done. But strictly in this hormone receptor positive group, we've found that as a multidisciplinary team, we are very comfortable with this, and we've found that patients are very appreciative of this conversation and the opportunity to de-escalate their local regional therapy.